You don't have an enclomiphene deficiency, you have a testosterone deficiency. The best way to improve testosterone levels is with testosterone, not enclomiphene. Right now, enclomiphene is getting a lot of hype in the men's health space, and I get it. I mean, on paper, it looks incredible. You take a pill, your testosterone goes up, your LH and FSH go up, your sperm count doesn't crash, it may even improve. You don't have to inject testosterone, you don't have to commit to long-term testosterone therapy. Telemedicine companies get to market it as this clean, fertility-friendly testosterone optimization option. Sounds amazing, but there are some caveats. Here's the problem. Raising testosterone in a lab report is not the same thing as fixing a testosterone deficiency. And that's where enclomiphene gets overhyped and overmarketed and can be used in the wrong patients. I don't think enclomiphene is poison. I think it has a use in a select population. So I'm not 100% anti-enclomiphene. I have a couple of guys who do really good with it, but I am very anti-hype and very anti-pretending this is the same thing as good testosterone replacement therapy. Because patients don't come to me saying, Mason, my LH is low, my testosterone number is hurting my feelings. They come in saying, I have no libido, no drive, my mood is flat, I'm not recovering, I'm losing muscle, I have erectile dysfunction, I just don't feel like myself. And so the question is, can enclomiphene raise testosterone? It can. But the better question is, does that increase in testosterone translate into symptom resolution? And the answer is not always, and not nearly as reliable as testosterone is, and not nearly as reliable as the marketing makes it sound. So let's kind of back up and let's just give some information over enclomiphene itself. Enclomiphene is not a brand new magical testosterone pill. It's one isomer of clomiphene citrate, which is a med called Clomid. Clomid is a mixture of two isomers, enclomiphene and zooclomiphene. Enclomiphene is considered, the more anti-estrogenic isomer, the part that helps stimulate the hypothalamic pituitary gonadal axis. Zooclomiphene has more estrogenic activity, hangs around longer, and may contribute to some of the weird effects that people get with traditional clomiphene. So the idea behind enclomiphene was pretty logical. What if we isolate the part of clomiphene that stimulates LH and FSH, raises testosterone, supports sperm production, while removing the less desirable estrogenic isomer? That is a reasonable drug development idea. And honestly, the mechanism is pretty elegant, but elegant mechanism does not always equal meaningful clinical outcomes. So let's simplify how this works. There's a hormone loop. Your hypothalamus talks to your pituitary talks to your testicles produce testosterone and sperm. The hypothalamus releases GnRH. GnRH tells the pituitary to LH and FSH. LH tells the Leydig cells in the testicles to make testosterone. FSH tells the Sertoli cells to function and make sperm. Then testosterone and estradiol feed back to the brain and say, hey, we have enough hormone, slow the signal down. That's a normal negative feedback loop. Enclomiphene blocks estrogen signaling at the level of the hypothalamus and pituitary, so the brain perceives less estrogen feedback. In response, guys don't have an estrogen producing organ, so the body is going to increase sex. The brain's gonna just amplify it. GnRH goes up, LH goes up, FSH go up. The testicles are stimulated harder, so testosterone goes up. Sperm production is typically preserved, and that's why enclomiphene has a place in secondary hypogonadism. Secondary hypogonadism means the issue is not necessarily the testicles are completely dead, it's just the signal from the brain is too low or inappropriately normal. Low testosterone with low or normal LH and FSH. This is the guy where enclomiphene makes the most biological sense. But if a man has primary hypogonadism, which is low testosterone with already a high LH and FSH, the brain is already screaming at the testicles. Giving more signal does not magically wake up testicles that cannot respond. And so this is my biggest issue with the lazy prescribing of enclomiphene. If a 60-year-old man has low testosterone and his LH is already 12, 15, 20, he doesn't have an enclomiphene deficiency. His pituitary is doing its job. The problem is downstream. More signal is not going to be the answer to dead testicles. And so enclomiphene was developed because standard testosterone has a major drawback. It replaces testosterone, but it suppresses the hypothalamus pituitary testicular axis. When you give exogenous testosterone, the brain says, hey, we got plenty of this, you're doing great. I'm not going to devote any more resources to this, so it cuts off LH and FSH signaling. So now intratesticular testosterone drops, and that means sperm production drops pretty dramatically in most guys on testosterone. For a 42-year-old guy who is done having kids and wants symptom relief, that signal being shut off is an acceptable trade-off for a better testosterone number with testosterone. But in a 28-year-old who is actively trying to conceive with his new wife, is not appropriate to bring testosterone in that conversation. Can we raise testosterone without shutting down fertility? And this is where Enclomiphene shines. It can raise total testosterone while maintaining or even improving sperm parameters. That's its strongest case. Not TRT without the risks, not testosterone replacement in a pill, not all the benefits of testosterone without. The most honest description is Enclomiphene is a fertility preserving stimulator of endogenous testosterone production in men whose testicles can still respond to LH and FSH. But that's not as sexy marketing as TRT in a pill, but it is much more accurate. The best Enclomiphene data show that it does raise total testosterone. It raises LH, it raises FSH. It preserves sperm concentration better than testosterone gel. That is real. In phase 3 studies, Enclomiphene increased total testosterone into the normal range, maintained sperm concentration, and the topical testosterone raised testosterone, but it suppressed the LH and FSH and reduced as expected. So if your outcome is, can I improve testosterone numbers while preserving fertility for PrEP, Enclomiphene looks good. But here's where the hype starts to fall apart. The FDA did not reject Enclomiphene because it failed to raise testosterone. It raised testosterone, but the issue is clinical benefit. The FDA essentially said changing testosterone numbers is not good enough. You need to show meaningful improvement in symptoms or signs of hypogonadism. And the Enclomiphene trials did not adequately demonstrate that. That is the entire clinical disconnect. A television ad can say raises testosterone because that's true, but the patient hears, I'll feel like I'm on an optimized testosterone therapy, and that's not always true. These are not the same claim. And so, labs can improve, but symptoms may not, and that's the part that gets missed. Enclomiphene works by blocking the brain's perception of estradiol, and I know some people still treat estradiol like it's just a side effect of testosterone, but I think that in men, estradiol matters. Estradiol affects libido, mood, erectile function, nitric oxide, bone health, joint comfort, brain function, possibly even some of the emotional well-being response men feel when testosterone is optimized. And so my personal clinical bias is that a large percentage of what men feel from testosterone optimization is mediated through adequate androgen levels plus adequate estradiol. And that's why we just don't use aromatase inhibitors. That's why I don't chase estradiol just because it flags on their labs. So with Enclomiphene, the irony is that the same mechanism that makes the numbers look better may be why some don't feel better. You're increasing LH and FSH, you're increasing testicular testosterone production, you may increase total testosterone, you may even increase estradiol because more testosterone can aromatize, but you're also using a SERM that blocks estrogen signaling in certain tissues, especially at the hypothalamus and pituitary. So the body may have more hormone on paper, but the brain may not be experiencing that hormone environment the same way it would with natural production or testosterone replacement. That is one reason I think some guys say my testosterone went to 300 to 750, but I basically feel the same. That's not imaginary. This is the difference between lab optimization and symptom optimization. The other reason is because SHBG. Some men on Enclomiphene see total testosterone rise, but SHBG rises too. If testosterone goes from 350 to 700, everybody gets excited, but if your SHBG climbs significantly with it, the free testosterone may not move at all. And the free testosterone is actually more reflective of what the patient actually feels. So a guy can have a beautiful total testosterone number and still have this same mediocre free testosterone number. And that's why I do not manage these patients off total testosterone alone. I want total testosterone and a free testosterone that's calculated with the SHBG and albumin. Albumin stays pretty standard. I just kind of put it at 4.3 every time, but it weekly binds it. So we're also going to check LH and FSH, the other blood markers like we would as well, your blood count, kidneys, liver, electrolytes, semen analysis whenever fertility is in the discussion, and symptoms, because that's going to be the biggest driver of treatment success. If a total testosterone doubles but the free testosterone doesn't move, I don't care how the screenshot looks in the patient portal. The patient did not come in to win a lab competition. Let's talk about one little part of it as well, desmosterol. Desmosterol is a cholesterol precursor. It's part of the cholesterol synthesis pathway. Enclomiphene labeling has noted that prolonged clomiphene therapy may raise desmosterol levels, likely due to an inference with cholesterol synthesis. And that label language is specific for clomiphene, not pure enclomiphene. And the label also says that serum sterols at recommended doses are not significantly altered. So it didn't really seem to be a panic issue. I'd not make a whole Instagram fear reel saying that enclomiphene destroys cholesterol synthesis. That would be overdramatic, but it's worth understanding. When you manipulate estrogen receptors with these older SERM type compounds, there may be effects beyond testosterone, LH, and FSH. Desmosterol itself is not just random garbage. It's tied to cholesterol biosynthesis, membrane biology, and lipid metabolism. Is a mild increase clinically meaningful in adult men on atypical doses? We don't really know. There's not enough long-term and clomiphene-specific outcome data to confidently say this matters or does not matter. So my take is, I'm aware of it. I don't overreact to it. I'm not going to be too scared of it, but also don't pretend enclomiphene is some perfectly clean vitamin with no downstream biology. That's kind of the adult answer. Another one that I don't hear discussed very much is the IGF-1 reduction. IGF-1 enclomiphene can lower IGF-1. And now, does a lower IGF-1 automatically mean the patient will feel worse? No, but IGF-1 is tied to growth hormone signaling, recovery, body composition, tissue repair, and just general anabolic tone. So when a guy is trying to lose fat, preserve muscle, recovery from training, improve energy, and feel better, I don't love ignoring a drug-induced drop in IGF-1, especially when the whole reason he came in was because he feels flat, under-recovered, soft, and not like himself. If enclomiphene raises his total testosterone but lowers IGF-1, increases SHBG, blocks central estrogen signaling, it's not hard to understand why the lab report may improve more than the human being. Again, this isn't every guy. Some guys do good on it, but this is why I don't talk about enclomiphene like it is TRT without consequences. It's just a different tool with a different trade-off profile. Enclomiphene is generally tolerated pretty well, but the no side effects marketing is nonsense. You know, the potential side effects can include headaches, hot flashes, nausea, mood changes, irritability, anxiety, depressive symptoms. It can still raise hematocrit, just like testosterone can. Sometimes it makes libido worse, sometimes better. Sometimes erections can worsen or remain unchanged. The biggest one is visual symptoms. You can't be a pilot and be on enclomiphene. And so it can cause floaters, blurred visions, flashes, scotomata, photophobia, and other disturbances. And so that exact mechanism is not fully nailed down, but estrogen signaling is present in ocular tissues, and with SERMs blocking that on the optic nerve, maybe that's why this is happening. So if I have a patient on enclomiphene who says I'm seeing floaters, I'm having flashes, my vision has changed, or I have blurry vision, that's not a push through, see if you'll level out. That's just stop the medication and we'll figure something else out. I've kind of been negative the whole time, but where does enclomiphene have a role? Candidate number one, a younger man with secondary hypogonadism who wants to conceive within the next few months. This is probably the cleanest use case. Low testosterone, lower normal LH and FSH, still wants fertility, not ready for testosterone. Maybe a reasonable use. Candidate number two, a man who's hesitant to start testosterone and wants to trial a trial of HTPA stimulation first. It's reasonable if we have an honest endpoint, but we're not doing forever labs to look better therapy on this guy. If he feels good, then we may keep it on. Does your symptom improve? Are we moving the free testosterone number? And with that free testosterone improvement, are we actually getting symptom resolution, libido improvement, mood improvements? Do you actually feel better? If yes, then we can try it for a little bit. I'm not one that I want to keep it on for years like I would normal testosterone therapy, but it's worth to bridge the gap in the time if needed. Another one that I may use it on is a guy coming off anabolics who wants a hypothalamus pituitary testicular axis restart. But mechanistically, enclomiphene can make sense as part of an HPA restart approach. A fourth guy, a guy with functional secondary hypogonadism from obesity, metabolic syndrome, sleep apnea, under recovery, overtraining, calorie restriction, but only if the root cause is being addressed. And this is important because if a man's testosterone is low because he's sleeping 5 hours, drinking too much, has untreated sleep apnea, is 80 pounds overweight, insulin resistance, inflamed, He does not have an enclomiphene deficiency, he has a metabolic problem. Enclomiphene may help improve that signal, but it does not fix why that signal is broken. So let's get into some bad candidates. Bad candidate number 1, primary hypogonadism, low testosterone with high LH and FSH. The brain is already screaming, the testicles are still not responding. So we don't just give the brain a microphone, because more yelling is not the answer. Bad candidate number 2, a guy who wants the most reliable symptom resolution and is done having kids. In that patient, testosterone replacement is usually the more direct and predictable there. Bad candidate number 3, a man with poor semen parameters who has not had a real fertility evaluation. If sperm count is 4, we should not just say, here's enclomiphene. We need to ask why. Is there a varicocele? Is there heat exposure? Is it from untreated sleep apnea, obesity, anabolic history issues? Is there a genetic abnormality? Is there a pituitary issue? Is there elevated prolactin? Low FSH, testicular injuries. A varicocele is one of the most common correctable causes of male infertility. So if a guy has abnormal semen parameters, sometimes the answer is still not stimulate harder. The answer is get evaluated by a reproductive urologist and fix the correctable problem. Bad candidate number 4, the guy who thinks enclomiphene is just oral TRT. It's not. TRT replaces testosterone. Enclomiphene stimulates the body to try and produce more testosterone. Different. So at my core, I always come back to this. Patients do not have, they have a testosterone deficiency, androgen deficiencies, fertility concerns, metabolic dysfunction, sleep problems, poor recovery, and some combination of these. So I'm not treating or chasing lab numbers only. I'm treating the patient. If a man has a true testosterone deficiency and is done having children, the best way to replace testosterone is with testosterone. But it doesn't mean every man needs testosterone. It does not mean enclomiphene is inherently bad for every patient. It just means we should be honest about the tool. Enclomiphene is not testosterone replacement, it's HPTA stimulation, and that distinction matters. And so here's how we explain it. Enclomiphene tells your brain to send a stronger signal to your testicles. If your testicles can respond, testosterone and sperm production may improve. It is useful if fertility matters, but it does not replace testosterone directly. And some men get better lab numbers without feeling better. We'll judge success by your symptoms, free testosterone, your SHBG, LH and FSH response, safety labs, fertility goals, and not just by a higher total testosterone. And that's the conversation patients deserve, not here's a magic testosterone pill with no downsides. So for men that I trial on testosterone, I still want baseline labs and follow-up. You know, baseline is just gonna how we're gonna be with the other one. Total testosterone with an SHBG so I can calculate the free testosterone. Let's see what your LH and FSH are. Let's get a prolactin just to make sure we're not dealing with a pituitary adenoma, CBC, CMP, lipids, hemoglobin A1C, semen analysis if we're discussing fertility, sleep apnea if that may be indicated, and testicular exam or urology referral if your semen parameters are poor without a true cause. And so at follow-up, are you getting better? You know, it's kind of the same follow-up as if we started testosterone. How are you feeling overall? And we'll see what kind of lab response you're getting. And again, the biggest mistake with this is checking only total testosterone, declaring victory. That's amateur hour. And so the most balanced way I can say it is enclomiphene can be a useful medication, but it's not a miracle. It's good at raising LH, FSH, and total testosterone. It's useful for a guy who wants to raise testosterone and preserve fertility. It can be helpful to kick things back into gear after anabolic suppression. It could be somewhat reasonable if someone's fearful of testosterone, but again, it just would rather put even that guy on testosterone. But it is wildly overhyped by telemedicine companies because the marketing is easy. Boost testosterone, preserve fertility, feel young again. Beautiful sales pitch, but biology is messier than a sales copy. And you know, some guys feel good on it, some guys feel nothing, some feel worse. Some get a higher total testosterone, but no meaningful testosterone. And if you get visual symptoms, if you're lowering IGF-1, you have mood issues, then it's an easy discontinuation for us. But most importantly, we don't have the same long-term symptom and safety study that people pretend that we have and that we have on testosterone. Testosterone's been around for 70 plus years now. So again, use enclomiphene when the mechanism matches the patient. Don't use it just because it's trendy. Don't use it because a telemedicine company made it sound like oral TRT. Don't use it with evaluating why the patient is low in the first place. And don't confuse better labs with a better man. And if you're a man considering Enclomiphene, ask your provider these questions. Am I primary or secondary hypogonadism? What are my LH and FSH? What's my SHBG? What's my free testosterone? Do I care about fertility in the next year? Should I get a semen analysis? Could I have sleep apnea? Is obesity limiting me? Are there any other medications limiting or metabolic diseases that are causing this? What's our endpoint? What side effects should make me stop? Because a good hormone care is not just about pushing testosterone higher. It's about matching the treatment to the patient, the physiology, and the goal. And so, just make sure the hype doesn't get you into trouble. And if you're interested to have any further questions over Enclomiphene, we're happy to be a resource. Or if you just want to know more questions over it, feel free to drop a comment, like and subscribe so we can continue to make videos, and then drop a comment on if you've used it and what type of response did you get. It does seem to be popular these days. I would just want to get more anecdotes out there, but thanks for tuning in.